the audio. I think she brought some stuff with her, right? Because we don't have any medical records at this point. They haven't made it yet. So she's got, I think, some med bottles with her, right? And like our syringe, is that correct? If that's not in there, I need you to tell me, because that's my assumption. That's how I recall writing the case.
I don't know if it's specified that she brought those with her or not.
Okay, she just told you? Okay, so we're working off that she's telling you she's taking warfarin and low molecular weight heparin. Any other objective data in the chart that you guys noted?
Her A1C came back and it was 9.5%.
Good, yeah, and let me clarify. We are going to talk about new data for other disease states, but for her VTE, what lab work did she have today? What are you going to use to adjust her therapy?
Is she enough? Let me see an INR.
I don't see an INR either.
I think you're referring to an INR, but I don't see it.
Yeah, I didn't see
Are you referring? Yeah.
It would be helpful to have an INR because she's on warfarin, but we didn't see one in the chart.
It would be really helpful to have an INR, especially when your facilitator is asking you questions like there is an INR in the chart. So, this lady's supposed to have an INR in the chart today of 2.1. I apologize for that oversight. So, her INR today is 2.1 in clinic before your visit. Now, just because I'm slightly doubting the completeness of my chart and module, I just want to make sure that I have in my notes what I intended for you to know is that she's going to bring in a bottle of warfarin, 5 milligrams daily, and enoxaparin, 80 milligrams twice a day. So we don't have medical records, but we have her syringe and bottle with those instructions on them. We have her INR today in clinic of 2.1. We have the information that she told us about the new VTE. So we're going to refer to the CHEST guidelines, right, for figuring out what's going on with her VTE, antithrombotic therapy for VTE disease. And the first things they start asking about is if she has cancer or if it's provoked or not provoked. So did she have a provoked DVT or a non-provoked DVT?
Provoked.
Provoked. I agree with that. What were her provoking factors?
Long car ride.
Yep. What else? What med did we just start?
Combined oral contraceptive with estrogen.
Yes. So we started her on an estrogen-containing product, and she went on a car ride. This is a provoked proximal DVT in her leg. So how long is she going to get treatment for?
Is it 3 months?
Yes. And then what drug do they recommend?
I could read that.
So it's point number 2 here, right? Patients with DVT of the leg and no cancer, they suggest the DOACs as first line over vitamin K. I will say, in practice, I'm still seeing a lot of both DOACs and vitamin K. So, questions for us to figure out today. She's concurrently taking warfarin and enoxaparin. Does she need to continue to take both? I'm seeing heads shaking no, right? She doesn't, right? What's that low molecular weight heparin for? It's to bridge her until her INR becomes therapeutic at 2. So she's got a therapeutic INR, great. So we're done with the low molecular weight heparin. So now we can either continue her on warfarin for her 3-month course of therapy, or we can get her switched over to a DOAC for her 3-month course of therapy. Because of the setting I work in and my practice history, I'm more comfortable with vitamin K. I don't have access to a lot of the DOACs, but in practice, again, the preferred DOAC would be the clinically correct answer, but I see both a lot in practice. So you're going to stop your low molecular weight heparin, you're going to select your continuing agent, and then you'll probably, if you're doing warfarin, you're going to follow up in a week. If you're doing a DOAC, it'll be more extended. And this patient, if it's a DOAC, we'll need to check in probably a couple times over their 3 months of therapy. If it's warfarin, it'll be based on INR analysis. So you're always going to talk about signs and symptoms of bleeding and clotting with people who are on anticoagulants, right? Drug interactions. And then if you're on warfarin, dietary recommendations as well. So I think her problem number 2 is now her PCOS and contraception, because that's tied into her VTE, right? So what are we going to do with her Sprintec pill or her combined contraceptive? Yeah. Would you feel comfortable retrialing this patient on estrogen? No, she's probably contraindicated for estrogen for the rest of her lifetime, for contraceptive purposes at least. So no more estrogen for this lady. So then you kind of have 2 thoughts, right? So that contraception was doing 2 things. It was contracepting and it was addressing PCOS. So now we have to address those 2 parameters. So let's start first with her contraception. What other options does she have for contraception now?
Progesterone, yeah.
Right. Yeah. So what are some examples? I'm sorry, I cut somebody off.
Sorry, I was just saying the progestin-only pill, like
Yeah.
norethindrone. I don't know how to say that, sorry.
Yep, norethindrone, 35 micrograms, the progestin-only pill, that would be appropriate. Pretty much anything that's not the combined pill patch ring, right? So typically, we want to pick the most effective options first. So those are IUDs and arm implants, followed by the depot shot, followed by the pill. So the pill would probably be my last choice of that spectrum. And then what are we going to do for her hirsutism? We said adds spironolactone. Yeah, so for distance people, I'm not sure if you heard, but we had a suggestion to add spironolactone. So those 2018 hirsutism guidelines that I suggested do recommend adding spironolactone for women who can't take hormonal contraception. I think that's great. What other disease state will that spironolactone potentially help with? Blood pressure, yep. And if we start spironolactone, what labs do we need to follow up with?
Potassium levels?
Yeah, so a basic metabolic panel to make sure her potassium looks good. Do you guys have any other questions or comments about her PCOS and her contraception? Awesome. So priority problem number 3, what do you think is next on the list? What else is she complaining of?
Yeast infection.
Yeast infection's back. So now we get to reassess it, right? How many is this? 4. So now she's got what? Recurrent. So how does that change our treatment plan? What do the guidelines say is the treatment for recurrent? It's pretty specific. It was in that paragraph under recurrent that one of the distant sites was asking about.
Fluconazole 150 milligrams weekly for 6
Yeah, you preface that with 14 days, right? Almost like a loading dose. So you do 14 days of daily fluconazole 150 milligrams, and then you do weekly for 6 months. All right, Parisa, what's her new A1C?
9.5.
Thank you. So her A1C has gone from 10 down to 9.5, which is great, right? Because we haven't even made it a full 3-month window since we drew that last A1C, right? Where she's been on therapy. She's only been on this new therapy for 2 to 4 weeks. So we're moving in the right direction, and we probably haven't seen the full effect of that therapy yet. We've noted there's some gray with that A1C, right? It's not showing us a full 3 months of medication. What other data are you going to use to decide if she needs insulin adjustment?
Fasting blood glucose.
There you go, fasting blood glucose. How many of her fasting blood glucose levels were between 80 and 130? 0. So I feel pretty good titrating insulin. So strategies to titrate insulin. How did you guys go about doing that?
2 to 4 units every 3 days.
Yeah, so we can send them home with the home titration. You can go up, usually I just say 2. I don't give them a window. Options just confuse things, but 2 units every 3 days until your blood sugar gets down to 130. Or you can just do a flat change. So that's more often what I end up doing in my practice. Sometimes my patients have problems with literacy and understanding what I'm asking them to do with 2 units every 3 days until blood sugar less than 130. If that's the case, I usually make a 10 to 20% change in their insulin. So right now, they're on a really low dose, probably 10 units. So that's going to be 2 units. But as they get higher, like let's say they're up to 30 units, and I make a 20% change, that's going to be a 6-unit change. So both of those strategies are fine. Today, you're right, we're going to change our 2 units either way. And for this type of patient in my practice, I see them every 4 weeks to continue to titrate insulin until their A1C is to goal. Once their A1C is at goal, then I back off to seeing them every 3 months, and then once their A1C has been at goal, repeat times, maybe only twice a year. You'll see different practices with different levels of titration, and a lot of it's just based on how available their provider is to manage that therapy.
Did you say 2 or 4 weeks?
2 to 4, yep. Depending on scheduling availability and how well the patient's doing with their instructions, hypoglycemia, and stuff like that.
So if you just went ahead and titrated it up yourself, you would just increase it by 2 units and just see them at follow-up?
Yes, and I would try to schedule the follow-up closer to 2 weeks if I could, because clearly we're not going to go as quick, it's not going to be as fast as if the patient did that home titration. I've always worked in indigent care populations. I'm hopeful one day I'll work someplace where I have a patient population that can do the faster titration, but I haven't had many patients that that's been successful with. So everything else with diabetes is pretty much the same. As we get their insulin adjusted, or perhaps their GLP-1 on board, again, the plan is to pull off that glipizide. Probably not effective anymore for this patient with her duration of diabetes. Increases the risk of weight gain and hypoglycemia like we talked about, but is there for us if we need it because she can't afford other meds. I'm going to move on briefly to hypertension unless you guys have more questions about diabetes. So we'll see her back in the 2 to 4 weeks, and I didn't specify, but of course we're going to do A1C every 3 months. So we'll be doing that in the near future too. What was her blood pressure today?
148/84.
Yeah, and I had, in my plan, I just increased her up to lisinopril 40. I didn't add the other med, right? If you looked at my plan on 126. So based on that, we saw some improvement, but she's still not to goal. And do we have any other new labs for her today? Specifically, we want to try and follow up on her potassium, right? Because we've increased her lisinopril. So if we don't have a current one, then we'll need to get a new one.
Her potassium was 3.6.
Okay. So that looks fine. So today, she's maxed out on lisinopril now, right? And she's still above goal. So I'd go ahead and move forward with that thiazide diuretic like we talked about. We're gonna have to do a basic metabolic panel to check our electrolytes.
I have a question.
Yes.
If we're initiating spironolactone, do we also want to still initiate the thiazide diuretic, or is the spironolactone going to be sufficient?
If I said thiazide diuretic, that was incorrect. I meant to say potassium sparing diuretic because we're initiating the spironolactone. So excuse me. We are initiating a diuretic today, spironolactone, for PCOS and for her blood pressure. Thank you for correcting. Nate, you're on it today. You've got me like 3 times with my mistakes. We're gonna have to put a stop to that. No more mistakes on my part, right? No, we're doing the potassium sparing diuretic, not the thiazide diuretic. Now, if she didn't have PCOS, we would be doing the thiazide diuretic, right? Everybody clear on that? But we're trying to use the spironolactone to double dip and cover her blood pressure and her PCOS. And she can be on a really high dose of this, right? So we're probably gonna start her on 50, and you can go up to 200 with spironolactone for like PCOS symptoms, whereas for hypertension, we usually only go up to 100 max. So it's a little bit funky with the dosing there because we're trying to cover 2 things. And then for lipids, there's nothing new, right? We're still continuing with our original plan, no new data.
She's still on the simvastatin, and I thought we were changing to a atorvastatin.
It doesn't matter as long as she is on a statin. So what I was trying to say earlier is because she is not specifically indicated for moderate or high, any of the statins are fine. I was more just excited that atorvastatin's on the Walmart list now and wanted to tell everyone. But either Simba or Atorva is fine. The exception would be drug interactions, right? With like if she was on amlodipine or something and we needed to take her off the Simba, but she's not on that. So, all right, guys, thank you for your attention today. So I tried hard to come up with a case that was appropriately gray and complicated, but concise enough to talk about in the classroom setting. If you have questions, I'd love to discuss it. I hope that this was helpful, and I will see you guys.
Bye.